All right, so today we're gonna do an Instagram live. We're gonna be answering some of your questions, but before we get to questions, we want to talk about the topic. Today is gonna be the management of miscarriages.
I think it's important to sort of talk about, what is a miscarriage. I think that's a great place to start. And so there's lots of terminology out there, I think, for different types of miscarriages. Basically, they are all kind of encompassing pregnancy loss. So somebody who is pregnant and let's say the pregnancy is not progressing the way that we expect, maybe there was a heartbeat, now there is no heartbeat, or somebody who the beta, the pregnancy hormone has started decreasing. Those are all instances of miscarriages. And each situation is unique, and the management of each situation is unique. But really what we want to talk about is situations where, let's say somebody was pregnant, they had a positive pregnancy test, maybe they've gone to their first ultrasound and we've seen something on the ultrasound inside the uterus, something pregnancy related, and then for whatever reason the pregnancy doesn't progress, doesn't grow in the way that we expect, or let's say there was a heartbeat and the heartbeat stops.
Right. Right. So now, before we start talking about the management, it's really important to talk about the fact that miscarriages are not your fault. And I know that you hear this all the time, but I don't know what it is. I think because obviously these are wanted pregnancies. Of course, women bond with their babies so closely, so fast, and almost every patient tells me, was this my fault? Did I do anything wrong? Was it because I exercised? Was it because I slept too much or too little, or I drank something, or I didn't eat enough? So I want to put it out there that miscarriages are not your fault. There's many reasons as to why they happen, and we can certainly go into that. They're not your fault, and I think it's really, really important to know that before we talk about management.
And I think it's one of those things that it's really important to reiterate and say that multiple times. It's not your fault. It's nothing that you did, and it's nothing that you didn't do. But for both partners.
Yeah. Absolutely. So in terms of management, we're talking about not a biochemical pregnancy. We're talking about something found on ultrasound inside the uterus that we now need to help you move from that. There are three main options. One option is what we call expectant management. So that would basically means stop taking the medications that you were taking to support the pregnancy and just wait for the pregnancy to pass on its own. The other option is medical management, and the third option would be surgical management. So in terms of expectant management, it's certainly an option. It's honestly not an option that we use a lot because it can take a long time. And one of the things when you have a miscarriage, most patients just want it to be done quickly. They want to be able to get back to trying to conceive again. As we know, time is important when you're on a fertility journey. So it's not uncommon for expectant management to take a very long time. And then obviously the anxiety of every day waking up is like, I'm not bleeding, it's not happening, when is it gonna happen, can be a lot. To put it into context, women who are not going through fertility treatment, it's not uncommon for somebody to pee on the stick, get to line, say I'm pregnant, and then have an ultrasound booked at 12 weeks of pregnancy for the NT. And then when they show up for that 12-week ultrasound, you could find that there was like a blighted ovum or a small sac that was measured in 6 weeks. So this person who wasn't even taking pregnancy support, who was not even a fertility patient, could have gone all that time where the pregnancy did stop growing and her body didn't really pass it. So that's why expectant management, while it is an option, it's not a great option because of how long it takes.
And it's just really, I think it's the mental challenge miscarriages can be really painful. There can be really, really heavy bleeding. Like, you want to set yourself up to sort of be ready for that. You don't want to have to be have tons of business meetings back to back, and all of a sudden the miscarriage starts, right? Like, that's incredibly challenging.
Absolutely. And the other thing now, if a patient, we do an ultrasound diagnosis miscarriage, she's already cramping, she's already bleeding, she's already passing clots, then that's a sign that the body's already trying to do this. And then that might be a reason to go with expectant management when you can see that things are already started to happen on its own.
Yeah, absolutely. The second option, of course, is medical management. And so what we mean is the use of medications to help progress the miscarriage along, to help get the uterus contracting, to kind of help get things moving along. There's a relatively new medication, or sorry, I shouldn't say a new medication. It's a combination of two medications. The one that's new, one that's really old, it's called mifeguimezo. And it's the most commonly used way to sort of induce the miscarriage. So mifeguimezo is a combination of two medications. So the first medication is called mifepristone, and that's kind of the newer medication that's sort of more recently been approved for use, combined with a really old medication, misoprostol. And so people who may have experienced miscarriage or had pregnancy loss a few years ago, at that time we were using just misoprostol, and sort of the mifeguimezo is a relatively newer addition to sort of that. So basically, in the way that it works, so if you're seeing your fertility doctor and they've been diagnosed with a miscarriage, we will provide a prescription for the medication. We do dispense mifeguimezo here in our dispensary as well, so patients don't have to go to another pharmacy. We can give it to them right away. It comes as one box, but it contains 2 boxes in it. We always provide patients with an instruction sheet about how to use the medication, just so that you have some helpful kind of information when you're at home. The first box contains the first medication, mifepristone, which you take by mouth. Again, it's just a pill you swallow. It is not meant to make the miscarriage happen. It may cause a little bit of spotting or light bleeding, may cause a little bit of cramping. It's really not intended to make the miscarriage actually happen. Now, it might, but that's not the intention. It's a medication that blocks progesterone. We know that progesterone is really important to support early pregnancies. So it blocks the progesterone to sort of prime the uterus almost for the second medication. So about 24 hours after you take the first medication, then you take the second box of medication, which is the called misoprostol. Sometimes we call it meso for short. So with the misoprostol, with the way that this protocol is written for the medication, you actually take it buccally, meaning that you put it sort of between your cheek and your gums, the pills, and you leave them there for about half an hour, and then if they don't dissolve completely, which they never do, then you swallow the medication. And then from that's the medication that's actually intended to cause the bleeding, the cramping, and to make the miscarriage happen. Usually after misoprostol, I tell people, maybe 3-4 hours, you'll start experiencing those symptoms. And then the bulk of the symptoms are happening over the next several hours after that.
Yeah, usually within 24 or 48 hours, the medication should have taken effect. And everything.
The second medication.
The second medication, would have happened. Patients ask all the time about pain, how painful this is. And of course, that's a very valid question. And it really is very variable. A lot of it has to do with the size of the pregnancy. So if the pregnancy, the sac is measured in 8 weeks, that is a bigger sac than a pregnancy that is measuring 5 weeks or 6 weeks. So I always talk to patients sort of based on that, but sometimes I've had patients with very small gestational sacs that are in incredible amount of pain, and patients with a bigger gestational sac that don't find it to be too painful at all. So I think the pain experience, just like anything else, is very variable. But we do prescribe medications like Tylenol 3s or NSAIDs for patients, because we want to make sure that pain shouldn't have to be part of the experience. Like physical pain shouldn't have to be part of the experience. We do give you medications, and I always say if the pain is too much, then definitely go to the emergency room, and then they can give you IV medications and eventually do a DNC if it's needed, which we're going to talk about soon.
Another big question I think that people always ask is how much bleeding is normal, how much is too much? In a miscarriage, it is normal to soak a menstrual pad in an hour. And we're talking truly soaking it, where you could wring it out. And that should only be happening though for a few hours, 2 hours, 3 hours, and then it should start to taper off. If it's continuing past 5-6 hours of that, then that might be a reason to go to the emergency room. You shouldn't be passing out. You shouldn't be feeling very dizzy or very lightheaded. Those are not normal. You shouldn't be having chest pain. You should not be having shortness of breath. Those are also reasons to go to the emergency room as well.
Absolutely. Patients also ask, how do I know I passed everything? And the question is, we don't really know that you pass everything until we do an ultrasound. So we do recommend anybody that has a miscarriage to have a medical management or expectant management to have an ultrasound to rule out any retained products. And this can happen about a week to 2 weeks later. And that would be really important because you don't know. Generally speaking, if you get, you take the medication, you have bleeding, cramping that goes up, loss of clots, and then all the bleeding like slows down, that's kind of a sign like, yeah, you did pass everything. But yeah, we always do want to have an ultrasound to make sure.
Yeah, absolutely. I mean, people will often say, oh, I think I saw clots, or oh, I didn't see clots, I saw this, I saw. To be honest, the 6-7 week size, we're talking about things that are 2 centimeters in size, the sac. It's extremely difficult to be able to recognize it, to see it. I certainly wouldn't be able to.
No.
And clots can get really large.
That's right.
Blood clots can be really, really big, especially if you've been sitting for a prolonged period of time. You definitely can be passing orange-sized clots, for instance.
Which brings me to the point that some patients are worried that they're going to see a baby and how they're going to feel. And I think it's important to reassure you that you don't see a baby. You see clots, you see tissue, but nothing that it would be recognizable from that point of view at that gestational age. We're talking about miscarriages prior to 8 weeks. It's a completely different conversation if we're talking later gestation. The other question is, how long can we start trying after a miscarriage? How long would it be before I get my period after a miscarriage? So that's usually about 6 to 8 weeks. It's important to understand that at the time of the miscarriage, your ACG will be positive because you were pregnant. Then the ACG has to go all the way down to 0. Then the body gets the message like, okay, I'm gonna ovulate again. So the FSH goes up, the estrogen level goes up, and then you'll ovulate. And if there's no pregnancy, then you'll get a period. So there will be a cycle along which is 4 weeks, and prior to that cycle starting, the ACG has to be 0. And that can take another 2 to 3 weeks from the time of the miscarriage. So overall, it's about 6 to 8 weeks to get a period. And then once you get your first menstrual period after the miscarriage, and again, the bleeding of the miscarriage is not a period. That's the bleeding related to the miscarriage. And there would be a period of no bleeding with an ultrasound saying there's no retained products, the uterus is clear, and then you'll get a period. And that's the period that we would count as your first period after the miscarriage, and that's the one that you can start using for timing conception and trying again.
And then, of course, we also need to talk about the DNC, the surgical option. So we've talked about expectant management, we've talked about medical management, and there's also the surgical management. So DNC stands for a dilatation and curettage. So it's a procedure that we would have our patients do in the hospital. They are in the operating room, they have anesthesia on board. Typically, it's like a deep sedation, meaning that you're gonna be asleep for it, so you're very comfortable for it. Probably without a breathing tube going down your throat. I mean, again, every person is different in terms of their medical conditions and medical history, but most often not using that breathing tube down the throat, so it's not a full general anesthetic. From there, the gynecologist who's performing the DNC will put a speculum in the vagina, and then they will mechanically stretch the cervix a little bit. So generally speaking, a cervix might be open a couple of millimeters at any given time, open a little bit more during when they're having their menstrual period, but we need to be able to stretch it a little bit so that we can actually pass our instruments through the cervix into the uterus and to be able to get the tissue out. So they mechanically stretch the cervix to 10 millimeters, 12 millimeters, depending on sort of how far along somebody is. And then they pass a device into the uterus. It's like a soft plastic that just basically has a little bit of suction attachment that helps remove the tissue that way with a little bit of suction. It's done not under ultrasound guidance typically, so it is a procedure where you're kind of doing it more by feel than by what you're seeing. All in all, procedure takes 10-15 minutes. It's very fast. You're awake in the recovery room, and then you are able to kind of go on with your day.
I think one of the benefits of the DNC is that you don't need to experience the pain and the bleeding at home and the anxiety that comes with that. So you can book at the hospital, you go in, you go to sleep, you wake up, and it's all done. That's definitely a good option there. I think the disadvantage is that it's a surgical procedure, so you need to be NPO, you need to be put on the board, you're usually on call, so it's not like we can give you an exact appointment. Being on call means you might be coming to the hospital at 1 p.m., maybe you're done at 6, maybe you're done at 8, maybe they cannot do it because there's other emergencies and you need to go home and come back again. With a surgical procedure, there's risk, there's a risk of infection, bleeding, perforation, And the more DNCs that you do, the higher the risk of scar tissue in the uterus as well. So one DNC alone is probably not going to cause scar tissue, but I always tell patients, we don't know if this is the last DNC that you'll need or if you're going to need other ones down the line. So we try to save those procedures for when there are no other options.
Yeah, I think when people will often ask, well, what's the best thing to do? And I think there's pros and cons of each of the three options. Like, none of them is perfect. None of them is a perfect answer by any stretch, and each of them will have their disadvantages or their cons, so to speak. But generally speaking, I think most of us will often recommend the medical option because it carries the least amount of risk to the uterus and for future subsequent pregnancy and future fertility, generally speaking.
Having said that, it's always a discussion that we have with all our patients, and some patients, I had a patient that was trying to do expectant and she was just in so much pain, and we brought her in and got her arranged for a DNC. So there are people who just prefer DNC because of many reasons, and that's totally an option as well. So it's always a discussion between the doctor and the patient.
Oh yeah, absolutely.